Hyponatremia. It's one of those topics that just always seems to pop up in exams, and honestly, it can be pretty confusing at the bedside. But what if you had a really clear, simple framework to handle it every single time? Well, in this explainer, we're going to build that framework together so you can confidently tackle any hyponatremia case that comes your way, whether it's in the ED or your OSCEs.
Okay, let's dive right in with a classic emergency department puzzle. So, you get a call, an elderly patient has had a fall, seems confused. Now, your differential diagnosis is massive, right? But one of the most important and frankly, often overlooked possibilities is hiding right there in their blood work.
This is an absolutely critical pearl. What a lot of people miss is that even chronic, kind of mild hyponatremia can cause these subtle but really significant problems, like an unsteady gait or just some cognitive slowing, which can lead directly to a fall. It's not just about those dramatically low numbers. So the rule of thumb is crystal clear. Any patient with a fall or confusion, you have to check their oohs and ees. All right, so before we can even think about treating, we have to classify. Building a solid framework is the absolute key to not getting lost in the weeds. This is exactly how you're going to structure your thinking, both in the exam and at the bedside.
The basic definition is super simple, right? Serum sodium less than 135. But that's just the ticket to the game. The real clinical decision-making, the important stuff, that all starts with how we classify it from here.
So the next question you got to ask is timing. Has this happened acutely, like in the last 48 hours? Or is it a slow, chronic burn? Now, most of the cases you're going to see will be chronic, unless there's a really obvious trigger, like a recent surgery. This distinction is so important, because trying to correct a chronic problem too quickly can cause permanent brain damage. We'll definitely come back to that. Next, we classify by severity, and it's all based on the numbers you see here. We've got mild, moderate, and severe, and that really critical cutoff for severe is anything less than 125. It's the combination of this number and the patient's symptoms that's going to tell you exactly how fast you need to act. Okay, let's move away from the lab results for a second and go to the patient's bedside. This is how it all builds into your initial assessment. You've got the numbers, now you need to look at the person sitting in front of you. These are the absolute red flags. I mean, stop everything and act now, red flags. If your patient is having a seizure, is in a coma, or has a significantly low GCS, you are dealing with a true medical emergency. These signs are telling you the brain is swelling and is in very serious trouble. You have to act immediately. Okay, now for the most important clinical question you have to answer. What is the patient's fluid status? Are they dehydrated? Are they overloaded, or are they euvolemic? Just right. Your history, your exam, looking for things like a postural drop in blood pressure or a raised JVP, and even a quick bedside ultrasound to look at their IVC will give you the answer. This single assessment dictates your entire management plan. Okay, we've classified and we've assessed. Now for the playbook. This is what you're actually going to do to fix the problem, both in that OSCE station and in real life. Let's be crystal clear about this. If you see those red flag symptoms we just talked about, you immediately launch into your ABCDE approach. Stabilize the patient first. The low sodium is the cause, sure, but a secure airway and good circulation are your absolute immediate priorities. This right here is your emergency weapon. For that seizing or comatose patient, you are giving a 100 to 150 milliliter bolus of 3% hypertonic saline. You're going to infuse that over about 5 to 10 minutes. This will rapidly pull water out of those swollen brain cells and stop the crisis. And you can repeat it if you need to. You have to know this protocol cold. So what happens if you don't have hypertonic saline just sitting there ready to go? Well, your second line is IV sodium bicarbonate. You're going to use the same dose, 100 to 150 milliliters, pushed over about 5 minutes. It's a really good backup plan to have in your mind. All right, let's switch gears and talk about the vast majority of patients, the ones who aren't actively seizing. For them, your management is entirely guided by the volume status you just figured out. And as you can see, the plan is completely different depending on whether the patient is hypovolemic, euvolemic, or hypovolemic. Let's break down why. This is such a critical pearl. For your hypovolemic patient, the one who's dehydrated, your first job isn't to stress about the sodium number. It's to restore their circulating volume. You fix the shock, you fix the dehydration, and often the sodium will start to correct itself. So when you're giving fluids, which bag do you reach for? Well, increasingly, a balanced crystalloid like Hartmann's solution is the preferred choice. Because its sodium concentration is a little closer to the body's, it raises the patient's sodium more gently than 0.9% saline, and that reduces the risk of overcorrecting.
Now, some guidelines, like the NICE guidelines in the UK, do still mention normal saline, but a lot of experts agree Hartman's is often the safer bet here.
Okay, if you remember one number from this entire explainer, please make it this one. Your maximum safe correction limit is 6 to 8 millimoles per liter in the first 24 hours. That's it, no more. And here is why that number is so critical. If you correct chronic hyponatremia too fast, you literally force water out of brain cells too quickly. This can cause a devastating, irreversible neurological injury called Osmotic Demyelination Syndrome. It's like stripping the insulation off of the nerve cells in the brain. Our goal is to make the patient better, not cause permanent harm. Slow and steady absolutely wins this race.
Excellent. Okay, let's lock in all this knowledge. Time for a quick rapid-fire quiz to make sure these concepts are totally ready for your exam. First question. Think about a patient who is losing both salts and water. What kind of conditions should be jumping into your mind?
Exactly. These are the classic causes where the body is losing fluid into what we call third spaces. Basically, it's leaking out of the blood vessels. Sepsis, pancreatitis, a bowel obstruction. These are the patients who are profoundly dehydrated. You should be able to reel these off instantly.
All right, next up, this one is huge in clinical practice. Your patient isn't dry, they're not overloaded, but their sodium is low. What common medications are you thinking of? That's it. SSRIs and thiazide diuretics are notorious culprits. This is exactly why a detailed drug history is completely non-negotiable for any patient with hyponatremia. These meds are incredibly common, and it's such an easy cause to miss if you don't ask.
So let's boil it all down. Here are your 3 key takeaways. First, always classify the problem by severity, by onset, and most critically, by volume status. Second, recognize the red flags. If you see severe symptoms, you treat it like a top emergency with hypertonic saline. And third, for everyone else, correct slowly. Always respect that 6 to 8 millimole per 24-hour safety limit. If you can remember these 3 steps, you'll be able to approach any case of hyponatremia with structure and with confidence. Good luck with your exams.